So, good morning. Thanks for coming to the last session of this awesome conference. Today we're going to be talking about decentralized STBBI testing. My name is Sandra Kazik. I'm from the work for the Public Health Agency of Canada, more specifically the National Microbiology Laboratory, which is based here in Winnipeg. Myself and Catherine Card here and Tracy Taylor will be talking about sort of the decentralized testing work that the lab and the agency has been doing for quite a number of years now. And then we've invited a special guest, Veda Konkan from Manitoba Harm Reduction Network, to sort of to talk about a very recent and very successful testing event here in Manitoba, and we want her to be able to showcase that and bring it to everyone's attention. So we don't have any conflicts of interest to declare or disclose. And I'll acknowledge that we are on beautiful but still chilly Manitoba territory, Treaty 1 territory here today. But acknowledge also that the work that we do spans multiple treaty territories and unceded territories across Canada, and that the work that we do is really guided by the calls to action to advance health equity, improve health outcomes for Indigenous people in Canada. So the decentralized STBBI testing journey that the National Microbiology Lab sort of has endeavored in has started, it's really with the goal of bringing STBBI testing to those that need it most. So we all know that access to testing remains inequitable due to many barriers, including geographic isolation, stigma, racism, testing hesitancy, among a number of other factors. Community-based testing is being recognized as a tool that can help address these persistent gaps in access, particularly for underserved populations. So our lab has been working for 10 plus years already, trying to bring dry blood spot testing into communities. And more recently, we've incorporated newer technologies like gene experts and point of care testing. My colleagues are going to discuss those aspects of the program. So here we go. So I'll bring Catherine up to the podium here to start her session.
Hi everybody, my name is Catherine Card. I'm a research scientist at the National Microbiology Lab in the HIV Reference Services section. Where did the pointer go? So dried blood spots have been used for decades for newborn screening, for metabolic disorders, and genetic diseases, but have also been implemented very successfully for quite some time into the tracks surveillance systems operated by the STBBI surveillance section at IPVAC's Infectious Disease and Vaccination Program branch. Since the early 2000s, these surveillance programs have integrated behavioral surveys with biological testing for HIV, hepatitis C, and other STBBIs. And the testing is done by our lab at the National Microbiology Lab. These are some of the outputs of the TRACS biobehavioral surveillance, which really focuses heavily on key populations in Canada. The success of DBS as a surveillance tool has led to our lab implementing it for STBBI diagnostics. And there are several aspects of dried blood spots that make it valuable as a surveillance tool, but also make it responsive to the barriers experienced by people who seek STBBI testing. We found that DBS has high acceptability, both among those providing the sample, but also those who are collecting it. And this is largely due to the flexibility of collection. Testing is available outside the traditional clinical setting and often by people who are non-clinical staff who have been trained to collect dried blood spots. It does not have to be performed by a phlebotomist, and often it's useful when people cannot use traditional phlebotomy, maybe because their veins are inaccessible or collapsing. So this is an alternative for phlebotomy in that case. Transport of DBS is also easy, so there are no TDG requirements or transport of dangerous good requirements, and the specimens do not have to be processed in a lab before shipping. The cards are simply dried and then packaged for shipment. They have good stability at room temperature or in the fridge, so in the case of testing events or surveillance work, they can be batched and shipped together. I'll get more into the testing in a minute, but the DBS format is compatible with multiple screen and confirmatory tests for different infections. So a full card can be used to test for several STBBIs and be integrated into the provincial reporting systems. There are also some disadvantages of DBS. So the turnaround time for results is longer, which can pose issues for people who are difficult to engage in care or to bring back for a second appointment for results. The tests also have reduced sensitivity compared to what you get for blood in a tube. So when a card is received at the National Microbiology Lab, the spots are punched and eluted into a buffer, and then the eluate is tested for hepatitis C, hepatitis B, HIV, and syphilis. The HIV Reference Services Lab at the NML offers both screening and confirmatory testing, diagnostic assays for HIV, hepatitis C, and hepatitis B, but for syphilis, we only have a screening test available, although we hope that sometime in the future we'll be able to offer a confirmatory test for syphilis as well. So we've seen year over year increases and sustained high numbers of annual testing volumes at the National Lab. These numbers include all of the tests for the different pathogens. And these are our annual test positivity rates. So we know from our provincial health counterparts that these numbers are considerably higher than what they are seeing at the provincial level for their testing programs, which suggests DBS is reaching the right populations. And here's an example of some of the testing results we see. So among samples that test positive for hepatitis C RNA, so that's active infection, we see that around 25% of them have high to very high viral loads, which is a risk factor for onwards transmission. So we are catching people with active and likely undiagnosed or untreated infection through this mechanism of testing. One of the most important measures of impact of DBS testing is changes at the structural level. So this figure highlights several provinces who have developed or implemented policy around acceptance of the dried blood spot specimen as a confirmatory result to satisfy positive case definitions for hepatitis C and HIV, and in some cases hepatitis B as well. Furthermore, a lot of the provinces are working right now to implement dried blood spot testing within their own labs. Currently, we get a lot of the samples collected across the country at the national lab, but there are provinces working to bring it on board themselves. And to help facilitate this, we offer proficiency testing for dried blood spot-based hepatitis C viral load testing. And the initial rounds of this PT program have been really successful with all of the participating labs showing excellent performance. In addition to the testing, we also have a DBS collection training program. This is a comprehensive training program and accompanying resources that are focused on proper DBS collection and packaging. And it's responsive to community requests. So if we get a request from a clinic or a community group, we can work with them to provide them with these resources. The resources include a video, a manual, and some other tips and tricks and that kind of thing, as well as evaluation. So this figure represents the distribution of DBS training engagements that we've had with community-based organizations, clinics, surveillance sites, and Indigenous community projects across the country since 2020. We've trained almost 100 sites, which translates to over 500 individuals. These individuals include a mix of nurses, healthcare providers, addiction counselors, peers, outreach workers, and others. and we operate under a train the trainer model, where trained personnel go on to train other DBS collectors in their networks. So the numbers that we see here, while recent, represent an underestimate of those that are actually benefiting from our training materials and implementing them in their settings. There's just some pictures here of various training and testing events. DBS has been adopted across the country, primarily in remote communities, including many First Nations, where it can be implemented in a clinic or nursing station, but also at community events and testing days. There's also urban decentralized community settings implementing DBS at places like Pride events. So just to summarize this section, DBS offers a low-barrier alternative to traditional testing options that address some of the social and structural barriers experienced by people seeking testing. And a full card can be used to test for HIV, hepatitis C, hepatitis B, and to screen for syphilis. Most provinces have implemented policy to accept DBS as a specimen type for laboratory confirmation of infection, but policies vary a bit from province to province. And then NML also offers training resources for the collection and implementation upon request. So the gaps experienced by dried blood spot based diagnostics are the slower turnaround time than traditional phlebotomy. So there's a potential for loss to follow up, as well as the slight reduction in sensitivity. But I'm going to pass the mic over to my colleague Tracy. She's going to talk about how some of the newer technologies actually help to bridge these gaps so that we can offer sort of more comprehensive toolkit for STBBI testing. Oh, sorry. Right. Before I move on to Tracy, I just want to thank the numerous communities and community-based organizations, sexual health clinics, and health organizations who've participated in this journey with us from the beginning of DBS implementation with surveillance to the diagnostics and decentralized settings that we're carrying out today, and appreciate their commitment to expanding access for testing for everybody. So this just goes forward, this one goes back. Thank you.
Okay, it works. Hello, everyone. Hello. Good morning. I'm Tracy Taylor, I'm the program manager for the community-based diagnostic program with the National Microbiology Laboratory. And so, while the National DBS program has significantly improved access to testing and informed policy development, extended turnaround times and connecting people to care remain a challenge. Community-based testing, meaning testing in community by community, is recognized as an important next step to address these persistent gaps that are essential to providing equitable healthcare services for all Canadians, regardless of their geographic location or socioeconomic barriers. I'd like to start also with my acknowledgements to acknowledge the people, communities, organizations, and other government departments that are leading community-based testing initiatives across Canada and have made significant contributions to improving access and advancing equity in STBBI diagnostics. This work would not be possible today without the extraordinary changes to the landscape of decentralized diagnostic testing in northern remote and isolated communities, also known as NRI communities. So the COVID-19 pandemic was a catalyst for change. At the beginning of the pandemic, limited testing capacity and slow results threatened outbreaks in NRI communities. Federal, provincial, and territorial support for community-based testing was prioritized to provide equitable access to diagnostics as a matter of justice and reconciliation. The NML launched the NRI initiative in 2020. Engaging community leadership and addressing local concerns were key to building trust and successful rollout of the program. The NRI initiative rapidly distributed point-of-care testing technologies, mainly the Cepheid Gene Expert and Abbott ID Now, along with over 1 million test cartridges, thousands of quality control samples, to over 600 communities and community-based organizations across Canada. To implement these resources, the NML hosted over 400 training sessions, primarily led through virtual platforms, but also in person when we were invited into the community. Over 1,200 training certificates have been issued to acknowledge successful new test operators, as well as new trainers through Train the Trainer learning sessions. The NRI initiative was proof of concept that widespread community-based testing in Canada is possible. Community-based testing cut result wait times from up to a week down to the same day or next day in most of these communities. And looking at these maps, it is evident that these locations are not only geographically isolated in northern communities, but are also abundant in the south, some of which are in urban centers and provide critical health services to key urban populations that are also isolated by stigma and discrimination and other social determinants. So these circles on the map represent First Nation and Inuit health centers, nursing stations, rural and regional hospitals, community and outreach clinics, pharmacies and harm reduction centers, senior and long-term care homes. And all of these locations are now equipped with the ability to perform diagnostic testing with sensitivity and reliability on par with laboratory-based testing. The success of the NRI initiative, let's talk about the reliability of results first before I skip ahead. The reliability of results is illustrated through the NML's external quality assurance programming, known collectively as QUASI, modeled after QUASI's long-standing international EQA program for HIV diagnostics. Proficiency testing for NRI communities provided confidence in the results, in the test operators, and in the equipment. And for the Gene Expert, both community-based testing sites and centralized laboratories were enrolled, demonstrating that community-based testing had the same level of proficiency and reliable results as laboratories. The success of the NRI initiative ultimately came down to community leadership, community engagement, and respect for self-determination and culturally informed approaches to testing. The NML's role in success was twofold. One, by providing the laboratory expertise and guidance necessary for implementation, and two, by building relationships directly with those in community, by making ourselves available to those on the front line, thereby strengthening our collaboration nation to nation. So it was clear following the pandemic that community-based testing is a powerful public health tool and is needed to address persistent gaps in access to diagnostics for underserved populations, particularly to achieve the goals set out in the Government of Canada's STBBI Action Plan. So post-pandemic, the Public Health Agency of Canada had contractual obligations to fulfill with manufacturers, but rather than buying more tests that were no longer needed, FAC invested in more Gene Expert equipment with the intent to address the core pillar in the action plan for increasing testing accessibility for historically underserved and undiagnosed populations through community-based testing initiatives. So the Cepheid Gene Expert is a device conducive to community-based testing. It simplifies and automates a PCR-based test using plug-and-play cartridges compatible with non-invasive sample types. Cartridges are available for a variety of different pathogens, including HIV, hepatitis C, and a dual chlamydia-gonorrhea cartridge. All of these tests have equivalent sensitivity and specificity to lab-based gold standard PCR tests, and they take anywhere from 30 to 90 minutes to run, depending on the type of test. So taken together, DBS, rapid antibody screening tests, and molecular confirmatory tests, such as the Gene Expert, combine to create a complete community-based testing toolbox for STBBIs that enables the possibility of testing and linking to care in a single visit. So using a simple finger stick, a patient has the option for antibody screening, followed by confirmation with a molecular test on the gene expert. Combining these options with dried blood spot collection or with phlebotomy is required in these early stages of community-based testing development to address ongoing gaps in continuity and alignment with provincial and territorial public health structures. So first, there are limited or no defined reporting pathways for CBT results. And second, not all provinces and territories accept CBT or community-based testing results for positive case definition. Hence, a parallel lab test using dried blood spots or a blood draw serves as both a mechanism for results to be entered into the patient's public health record and as a means for the provincial or territorial lab to validate the result obtained from the community. And in addition, as Catherine had discussed, the dried blood spot also provides more options for additional tests, as well as the option for the patient to delay receiving their results when that same day test and treat is not desirable. In August 2025, Health Canada authorized the Gene Expert Hepatitis C viral load fingerstick assay for use in non-laboratory settings, and this was quickly followed by a surge in demand for this technology to be implemented in community health centers with hepatitis C microelimination goals. To date, the NML has supported, and that should say 8 community health centers in 4 provinces to onboard this assay in conjunction with rapid testing and dried blood spot collection. In turn, we've developed an HCV branch of the quasi-EQA services to provide proficiency testing on a biannual basis. Non-conformances detected through proficiency testing include things like failed tests that are due either to device or cartridge failure, in some cases poor sample handling skills, and often simple transcription errors when reporting results. All of these non-conformances are quickly addressed through comprehensive corrective and preventative action, recommendations from the NML laboratory team to ensure reliability and accuracy for ongoing community-based testing. And we intend to take a similar approach to HIV testing. However, at this time, the Gene Expert Diagnostic Assay for HIV is not approved by Health Canada yet, but we are working closely with our partners at Reach Nexus in particular to support the clinical validation of this assay as part of the Rapid Testing and Linkage to Care initiative. And in addition to the Gene Expert HIV viral load assay, that one is approved by Health Canada, and we're working with our partners from CAHR to train our first pilot community-based testing site tomorrow morning. So stay tuned for results next year. So just to summarize some key takeaways, which seem to always be in progress as we are always learning and adapting to improve and align our services with the needs of underserved communities. Community leadership matters. We, being the National Microbiology Laboratory, we strive to stay in our lane as we are always, as we provide laboratory expertise and technical support. But success is only possible when driven by peers and the community. Community-based testing is essential to improving equity in healthcare services. We must bring diagnostics to the patient and not the patient to the diagnostics. We must meet people where they're at in order to reach the undiagnosed. And we must invest in capacity, not just technology, but invest in people. We acknowledge the need for wraparound care, including pre- and post-testing counseling, housing supports, harm reduction, and other social services. That testing is only one spoke of a holistic approach. The holistic approach is only possible thanks to collaboration with some key organizations that the NML is working with to advance community-based testing for STBBIs. And I've mentioned ReachNexus, CANFAR, as well as CTN Plus and VIRCAN, all leaders in this space and making community-based testing a reality in Canada. In closing, I am very happy to introduce Vida Conchan, the Projects and Research Manager for the Manitoba Harm Reduction Network. The MHRN works toward equitable access, systemic change, and reducing the transmission of STBBIs through advocacy, policy work, education, research, and relationship building. I had the pleasure of meeting Vida last November when we worked together on a 3-day training workshop that she coordinated, in which 14 MHRN staff from across Manitoba came to Winnipeg for hands-on training in the complete community-based testing toolbox for DBS, rapid tests, and the Gene Expert. This was an important knowledge-sharing workshop that demonstrated how these technologies could be incorporated into peer-led testing, identified barriers and possible solutions, and came to fruition in a community testing event in Swan River, which I am going to pass the microphone to Vida to tell us more about that. Thank you very much.
It'll be next. Okay.
They might just have to be loaded.
Mm-hmm.
Oh,
There we go. Okay. Hi, folks. My name is Vida. My pronouns are she and her, and as Tracy said, I'm the Projects and Research Manager at the MHRN. I've worked there for 14 years, and I came to this work as a raver kid that's currently in a much more boring phase of life, but hope to return. This was my first time filling out one of these conflict of interest things, so I hope I did it right. I probably erred on the side of oversharing, but like most folks that work at nonprofits, I also do side hustle consulting, and as most people at nonprofits, we accept money from various people, including for-profit businesses. We already did our land acknowledgement for this territory, but I'm going to be talking about Swan River, which is a part of Treaty 4 and a signatory to the Treaty 4. Like all treaties, this treaty was exploited by the colonial state and resulted in the health disparities that we're talking about. One of the TRC calls to action calls for governments and various other bodies to acknowledge that the poor state of Indigenous health in some communities is a direct result of this. And I'm not the government, but I choose to acknowledge that every time I talk. The Manitoba Harm Reduction Network is a network of networks. We have 11 sites throughout the province. Each of these sites has a local person that is our network coordinator, and each of these sites has a peer advisory council of people who use drugs. The network coordinator is responsible for coordinating services in the area and improving access to harm reduction and whatever the peer advisory council tells us to do, essentially. Our goal is to improve access and health and wellness outcomes, and also to have fun most of the time. Our Swan River site is the one we're talking about today, and they're called the HELP Network. It's run by our super industrious and passionate network coordinator, Chelsea, and all of this is really a result of her work. Unfortunately, she's really busy right now and wasn't able to come. We recently, through a FAC agreement, hired a second staff at this site, and this person is our navigator. And the navigator just started a couple weeks before the event, and her role is to support people who use drugs in accessing healthcare as determined and defined by people who use drugs. So it includes a lot of rides, it includes a lot of basic needs support, it has included buying people glasses or other stuff that they need. And one of our managers, Dolores, also happens to live in Swan River. Swan River has about 4,000 people, but it serves as a hub for the whole Swan Valley, which includes 10 communities and 2 First Nations. So Chelsea has been doing this work in Swan River for a number of years and was pretty
shocked when she learned that the people she was working with had hepatitis C, wanted to get treated, and couldn't get treated, as was correct. It was pretty awful. So she has been doing a lot of work to identify barriers and work to solve those barriers. And she has been saying for at least 2 years now that the folks she's hanging out with are ready for hepatitis C treatment. And it's not their own readiness or willingness that is what is stopping them from being able to access that treatment. I'm sure folks in this room know a lot about the systemic and social barriers that are what made it hard for people to access treatment. And one of our ways we worked to address those was to plan the Swan River Health and Connection to Care event. This was a 3-day event that just happened the last week of March. So we're still even gathering data, we're still seeing the results of this event because it's only been a few weeks. We had support from various folks to put on this event. The catalyst was a $25,000 grant from AbbVie, but it really leveraged all the existing work we were doing in that area, in particular really close partnerships with FAC and the Prairie Mountain Regional Health Authority, and recent training on the Gene Expert and all these technologies Tracy talked about. This event didn't come out of thin air. It, of course, built on all of Chelsea's work, including the pilot project. That's a picture of it there. And it's available on our website. And it's a really in-depth investigation of all of the barriers folks were facing and some of the things we were trying to do to address those barriers. Through that project, we knew we needed more support, and that's why we were able to apply to FAC to get a navigator at that site. It also built on quarterly testing and treatment events that Chelsea was already doing there that were really instrumental in getting people used to this process and building relationships between the folks that we work with and the medical staff, which were the existing relationships. This wouldn't have worked if this was just a drop into this community kind of situation. It only worked because this work had been going on and building towards this. It, of course, included extensive planning, which included consulting with folks we work with, our peers, about what they wanted it to look like, where they wanted it to be, what they wanted to eat, who they wanted to be there, who they didn't want to be there, and also a lot of stakeholder engagement and troubleshooting. It was kind of an amped up version of the testing and treatment events that we already do as an organization. There was a lot of troubleshooting and more than I can go into here, but for example, we needed a doctor who was willing to attend and do prescribing. We needed pharmacy support. We really wanted to get meds in hand within the same event time frame. We wanted people to leave with their treatment. There was also issues with tech access and charting because we were bringing people together from different areas. There were sort of logistical issues for almost everything. But it happened. We were able to provide the event and provide lots of services. We did the STBBI testing, the community-based stuff that Tracy talked about, using all those tools, point of care, dry blood spot, and Gene Expert. These tests were carried out by the MHRN team, so us, and we're not nurses, but we were able to figure it out, so it really shows how accessible they are. The first picture is my coworker Amber, who's our network coordinator from Portage La Prairie, doing the first test of the day. Then the second one is our little stack of DBS cards. And the last one is our FibroScan closet, because we work with what we have and we wanted to be able to offer FibroScans, and the only space we had was a closet, so we made it work, which is very much the MHRN way. We, of course, also had cultural support that was embedded throughout the event. And yeah, all these awesome services, mental health, dietitian, all that stuff. So our process at the event was that, this was really a hepatitis C focused event, was that folks saw the public health nurse, and the public health nurse was able to know, based on her files, if folks already had a recent positive antibody screen or confirmatory test. If folks already had both of those, they could skip our table and go straight to the doctor for their prescription. If they had a positive antibody but didn't have a confirmatory test, they could go right to the Gene Expert. And if they didn't have either, they would go first to point of care, and depending on the results of that, either go through the Gene Expert or not. So we had 141 folks attend the event over the 3 days. 34 folks got on hepatitis C treatment right at the event, 37 by the end of the week, and 41 by April 10th. Yeah, so it was great. Public health saw 100 clients, so the 100 clients is the amount that actually got screened. Not everyone chose to go through that process, which is fair. We did a lot of vaccines, especially on, public health, we don't do that part yet. Did vaccines, especially on folks who are HIV positive. We also did depot, birth control, pregnancy tests happened, kind of the whole gambit of things that a public health nurse might offer. We did 3 PrEP referrals, but those were not able to get started right at the event. Also prescriptions for Suboxone and out, as you might imagine. Of the 73 fibro scans, 12 folks had advanced fibrosis, which can impact treatment. So having the fibro scans present, was really, really helpful, and we're very thankful. Leslie Gallagher came from Saskatchewan to help us out with that. The primary care and outreach nurses did the HIV care, and one of the nurses stated that one of the folks she'd been looking for 4 years came to the event. She knew this person was HIV positive and hadn't been able to do any follow-up care for 4 years until this event. Another really amazing success was a nurse practitioner from the local First Nation, Sapatoyak, came and sat with the doctor for the whole 3 days and trained in how to do Hep C treatment. And the next week, she started one 2 days later, so in her own community. So that was a big success too. Another success, there's just a lot. The whole thing could be called like unanticipated successes. A 54-year-old got tested for the first time. We were able to treat folks that were in relationship with each other to, help prevent co-infection. We knew it was going to be really successful. It just was more successful in even more ways than we anticipated. So this is the first box of meds that was obtained on the first day of the event. I blocked it off because of that disclosure statement at the beginning. I don't know what I was doing. But the person that got these meds was someone that is known to our whole team as someone who had a high readiness for treatment, was pursuing treatment, had gone to multiple appointments trying to get treatment, had support of our team, and also support of his mom, and his mom's holding the meds there. And so when he was the first person to walk out the door with treatment, we all had to kind of hide our faces and cry for a second because we were so happy that he was able to get it. And that, his mom's holding them because she was really happy too. Just highlighting the gene expert. So you saw that we had 141 people attend the event, 100 people go through the screening process. The gene expert ran on 45 individuals and had 30 folks have HCV detected. So you can kind of see through those numbers, it's like a third of the people that really had the right people coming through the door for this event. The error and the invalid, those folks both got retested, so that's why it's 45 total gene expert tests. Another success of the event was telling people they were cleared. So you can see there was 15 folks who tested positive for an antibody test, and then HCV was not detected through the gene expert test. There was one woman who was crying, and she said, I thought I was sick. And so it was really meaningful, too, to give people the results that their HCV was cleared. And so people got to walk away from the event feeling really good. There was, of course, a lot of challenges. For treatment, one of the huge barriers that we're running into is that for NIHB coverage, the gene expert results are good enough for treatment coverage, but for folks that are not covered under NIHB, it's not. So the 2 folks that didn't start till April 10th, it's because they did not have coverage under NIHB. Now, most of the folks we served were covered under NIHB, but it's still something that was a huge barrier for those 2 folks. And they couldn't start treatment at the event because of those delays. Med access, so we did have a great partnership with 2 of the local pharmacies that are owned by Neighborly, but obviously folks can choose which pharmacies they want to access their meds from, and for folks that didn't choose one of those pharmacies, those pharmacies couldn't actually get the meds. There was a shortage at the warehouse and stuff that I don't totally understand. So they weren't able to get their medication from their first choice of pharmacies. It was super busy, this event, 141 folks, this many people going through screening. Our nurses, our testing stations were running at full capacity. We had lineups to get to the gene expert, even though we had 2 machines tied together, so we had 8 slots in the gene expert running. They were running the entire time. The nurses were running the entire time. The nurses really need more support. They were charting all night. They were charting all weekend to just catch up after this event, so we definitely need more support. Tracy mentioned in her presentation that we need to pull DBS in addition to the gene expert because we don't have a way as community members to report those results. From the participant perspective, we're not poking them extra times. We're able to use the same draws, so that's good, but it's still just a whole other step that is unnecessary. And literally the follow-up on for my team and why Chelsea's not here is because these folks that started on treatment, these 41 folks, a lot of them need daily support in accessing their treatment. We know from like social work that the ideal caseload is like, for folks that are needing a lot of support, is 10. And my team is supporting 41 folks really intensively right now, a lot of them with daily med pickups. And this is just what someone wrote on their, so there's one picture, which is that we like decorated med containers for folks to take their meds and vitamins, so that was really fun. We love a bedazzling moment. And this was just something, we had our evaluation forms, and someone wrote, how can we get a hold of you, smoke signals? Which, in addition to being funny, is also, this person is not lost to our team, right? They write smoke signals on this form, but my team is there living in community, and they know how to find them. So we don't lose people to care, even if we don't have a phone number, because we're right there. That said, it takes a lot of work. So some of our takeaways, and we are certainly still compiling data and stuff from this event, but one of them was that the 3 days was essential. Our previous testing events were all only 1 day, but we found having 3 days in a row, folks came the first day, brought their friends the second day. We had people accessing testing on the second and third day, whether or not they had attended previous days. So for some people, they had to warm up to the idea of getting tested, and also to bring their friends. So we're even talking about having a 4th day next time. Having all the different stakeholders was super important and beautiful. They consulted and solved problems right on site. For example, to avoid multiple pokes, our friends from the lab talked to the nurses and realized if they were already pulling phlebotomy, if they put it in the purple cap tube that you guys probably know the name of and I don't, then we could use that blood also for the gene expert and dry blood spot without additionally having to do a finger poke. So we were able to do problem solving just because of the people on site had the expertise. We also had some Hep C experts like Leslie Gallagher from Saskatchewan who was able to consult on complex cases, and we had the pharmacy, the doctor, the experts all there together so they could figure that out together, and that was really helpful. The time commitment is important to anyone considering doing an event like this, especially in the follow-up. The in-kind hours from all of the stakeholders were huge, including healthcare and even the folks who cooked the food for us. They did that in kind for us from the Friendship Center. So it was really a labor of love by lots and lots of folks. So, and also the relationships between the Swan River staff and the peers are the only reasons this worked at all, and building on the relationships that also the peers have formed with the nurses through doing our previous testing events. There's been a lot of logistical challenges, but the fact is that now we're having to deal with those challenges as the system instead of individuals having to deal with them. So our next steps are that we're doing stuff like presenting about it to try to get more support for events. We're going to be talking about this event. There's a press release on Friday that our friends at Reach Nexus did, and we're also going to be presenting about it to folks like the province to try and get more support. We want to replicate this event at other sites that have high test positivity. We just entered into agreement with Reach Nexus and Gilead to fund a navigator position in the PA. So now we're going to have a second person in the PA so that we can do an event like this there too, and have the staff power to do the follow-up. Now, it'll take a little longer in the PA because we don't have some of everything that Chelsea set up in Swan River already, but we're excited to do it there. We're also excited to do more work in Swan River. My big dream is to just like liberate Chelsea so she can focus on this work instead of her whole other job, and work towards eliminating HCV and also meeting the HIV 95 targets, because though that wasn't the focus of this event, it was still obviously something we got to work on. That's it.
So I'll open the floor to questions from the audience, please.
Hi, guys. I'm Sherry. That was an excellent initiative and excellent presentations. And I'm glad you mentioned at the end that, so you also did some HIV testing? Okay. So I have a question, because I'm not doing that much testing and prevention work right now, and I'm very curious if there's been any movement with the reporting requirements. Obviously, we want to follow and report cases, but has there been any movement to non-nominal reporting to public health? Because, I mean, really, with a cure and with U equals U, why do we have to nominally report? All it is policing, in my opinion. Just curious if there's any movement.
Is this on?
Yeah, so that's why, like in the case of the Swan River event, why DBS was used, because DBS was used to basically satisfy case definitions. Unfortunately, that's just the way it is right now. I mean, we're working towards, educating and getting people to understand and trying to make changes in the system, but we're confined by the current rules, right? So
It also varies a lot province to province, so it would be great if the rules were the same across the country, but to my knowledge, every province does have that reporting requirement, and part of it is also the linkage to care. So that's not something that can't be reinvented, but at this time, I don't know of any of the provinces trying to address that requirement.
This is not my expertise as much as it is these guys, but I think there's a role for like self-test in that too. If we can empower communities to get educated and be able to do self-test, then they can choose whether or not they're going to enter into the system. And if you're interested in this line of thinking, I've been thinking a lot about Alex McClellan's work, and he has sort of talked about the right to not enter into the system. And I'm certainly thinking about it, whether or not I'm able to do it right now.
Everyone, Mia Biondi from Toronto. Great talks across the board, such impressive work. 2 questions, maybe the first one is quicker. With the Cepheid chlamydia gonorrhea, has the NML done anything around pharyngeal or rectal validation, sort of in an off-label space? And then my second question, probably for Catherine, more complex. Is there going to be a change in the ability of the NML to train community on DBS? I don't want to say I've heard rumors, but I've heard rumors. And so I just wanted to understand like capacity of onboarding new communities to do training for DBS in their own space.
Yeah, I guess I can start with the first question and the validating the chlamydia gonorrhea. My program is not involved in that validation, and once the test has been approved by Health Canada, we do a small verification based just on urine because we're really focused on the point of care test. So we haven't looked at it in more depth. Not to say that might not be being done at the lab elsewhere, though.
As for the DBS question, so our program has evolved a lot from initially we did a lot of in-person engagements and hands-on training, but with the development of our video and some of the other resources, that's our primary model of training right now, is providing those resources for people. At this time, that is still 100% available. Upon request, we can definitely share those resources. And there's been a lot of reorganization at FAC and NML, but that has not been discontinued at this time.
I just want to ask the panelists a question from the community perspective because I represent the sex workers in Nairobi, Kenya. having the reduced funding and most of our clinics are closed down, and we've realized that there's increase of STIs and lack of uptake of condoms. So what lessons can we learn from the panelists so that we can also go back and adopt in our countries to reduce on the same? Thank you.
I mean, I feel like it's stuff you already know. I feel like it's turn it into a party. I feel like it's conversations with elders and leaders in the community and doing stuff with your hands while you do it. And I mean, if I understood your question correctly, you know, we just make condoms and stuff a part of everything that we do. They're destigmatized. So are harm reduction supplies, you know. They're in the bathroom, they're on the desk. Anyone can grab them anywhere, and we really work towards making sure folks can do it in private if they want, and also have a chat with us about it if they want, as well as some like formal education and stuff. I mean, we do whatever the peers tell us to do.
Yeah, I think maybe in addressing sort of the funding side of it, that's obviously very challenging. Manitoba Harm Reduction Network has been exceptional in their leadership and their initiative and attracting that funding, because they're really making things happen.
We sell t-shirts too.
Yeah. But some of those partners that we talked about within Canada are, you know, they're essential to making this work happen. Sorry, probably not a great answer for you.
Okay, I think that's it. So, any more questions? Are we good? Thanks everyone for attending this final session. Enjoy making your way home. Safe travels.